So hi everyone, my name is Phedias Diamandis, and I want to talk today about some neurodevelopmental defects that we encounter in neuropathology called Neural Tube Defects. I want to go over an overview of the disorders and the embryology that's associated with them. So this is mostly for trainees. This is for educational use only and not meant for diagnostic purposes. The main goal of these lectures and this series is to really ingrain the pathophysiology of these disorders to help you remember the various complex disorders and the spectrums and the subtypes as best as possible by really focusing on the theory and emphasizing the the kind of diagnostic criteria slightly less in these presentations. So keep that in mind. This is a very a challenging topic, I think, because there's a lot of new words and a lot of new definitions. And I think to properly understand them and remember them, there is a need for repetition. So I'm just making that clear from the beginning. That there's almost a two-part series to this presentation where I'll give a brief overview of the embryology of neurodevelopment. I use that as a springboard to define some of the key pathologies surrounding neural tube defects and the various variants that are grouped together in these spectrum of disorders. Then we will go back to the embryology just to really focus in on some of the specifics that may be going wrong in different disorders of the neural tube closures. And then we'll go back to the neuropathology and just review some of the gross and microscopic findings that you may encounter for each specific disorder. So I like to give a kind of general overview of neurodevelopment when I give talks on focal neurodevelopmental disorders, because sometimes if you just focus on the exact process that goes wrong, it's very hard to contextualize it in the 40-week neurodevelopmental period of the developing fetus. And so these are the major milestones of neurodevelopment. It begins with a process called neurulation, which is where you develop the neural plate, which will then go on to fold and close on itself to form the neural tube. This is the key process we're going to be focusing on in this lecture. This neural tube will undergo massive proliferation and expansion to form the kind of neural stem cell population that's going to derive the neurons and glia of the cortex. First, they undergo neurogenesis, so they generate neurons. These generated neurons migrate to their correct position in the first half of development through a series of early founder cells called Cajal-Retziat cells. These then coordinate both the radial migration from the dorsal ventricular zone to form the glutaminergic neurons of the cortex in an inside-out fashion. And then there's tangential migration from some of the ventral ventricular zones to form the GABAergic inhibitory neurons. Only then do you really get the generation of glial cells through gliogenesis from the same ventricular zone. So for the sake of repetition, this is a nice diagram that one of my former students made highlighting this process. So again, you have neurulation in the first few weeks of neurodevelopment. In the first, let's say, 4 weeks, the neuroectoderm is stimulated by the notochord to fold upon itself in the midline and form this neural tube. And then this is the structure that's going to lead to the central nervous system. Again, as we mentioned, it undergoes a process of expansion, proliferation, and then neurogenesis in the first half of neurodevelopment to form the neurons. These will migrate out into the ventricular zone, into the cortical plate. Then in the second half of development, the same structure will generate glial cells. And then only then will you have synaptogenesis, neuronal maturation, myelination, and synaptic pruning later in development and through adult life. So again, we're focusing really on that first step. And the key, I think, to bringing that all together is that events and defects that occur early usually have a profound kind of exponential effect on the fetus. So early neural tube defects and early embryological defects usually lead to many non-viable fetuses. The disorders that we'll talk about today are, however, on a large spectrum. And so it's important to understand that and understand that some of these may actually not even be neural tube defects. They may be more associated with axial, skeleton, and mesodermal development. And so part of them is grouped based on convenience and similar concepts, but whether they're all, in fact, true neural tube defects remains somewhat contentious. So there's many ways to group these disorders that we'll talk about today. Some people group them in a predominantly anatomical manner based on where they occur. But I think I always like to bring back stuff to development. So I like to group them based on first neurodevelopment and then anatomical, because it's easier to understand kind of biological processes in my mind than it is to understand anatomy. So the first is really a failure of neural tube closure. So that neural tube that we saw forming in the first weeks of life, it fails to close, and then there's secondary bony defects. And examples of these that we'll go over today are craniorachisis, which leads to a process called encephaly, and then another disorder called myelomeningocele or spina bifida. Bifida means the spine is split up into two parts, as we'll see. And these are really the most severe form. Again, these are true neural tube defects. I think that's not controversial. There is a second group of lesions that are thought to have relatively normal neural tube closure, but there is a defect in mesodermal development, and the mesoderm forming the kind of skeletal vertebral structures around the spinal cord and the cranial vault forming around the brain, and these have a spectrum of severity based on how affected the brain is from these defects. The main ones are encephaloceles, which is that the defect occurs in the brain, and meningocele, which means that the defect can occur really anywhere. It can occur in the spine, but also can occur in the skull, depending on what's herniating through the bony defect. And then the third group of disorders are called defects in tail bud development. This is really disorders of secondary neurulation. We'll get to that, what that means. But these really are called closed spinal defects, spina bifida occulta, diastomatomyelia. These are more minor and subtle disorders, some of them which may be asymptomatic in life. But these are, in fact, three different distinct neurodevelopmental processes that we'll talk about today that will hopefully help you compartmentalize this kind of large number of new terms in a fairly easy to remember fashion. So again, neural tube defects are really a spectrum of congenital malformations of the central nervous system, the nervous system, and axial skeleton development. We're going to start with the most severe ones, which really are open defects resulting from failure of the neural tube to close. And therefore there is direct communication of the neural tissue with the external environment, which is the amniotic fluid. This is a toxic substance for the nervous system and leads to kind of brain degeneration. So the most severe form, as you can see in the picture on the right, This is the embryological structure of the neural plate, which is really ectoderm that has been inhibited from receiving BMP, and this causes a neural state or the neural plate. And once this is formed, it's then coordinated to fold on itself, as we saw in the previous picture, to form this tube-like structure and kind of sever itself from the ectoderm, and that's going to be the spinal cord and the brain. Now, if these neural folds or these edges of the neural plate that are supposed to be folding and fusing with each other don't fuse, then you have a complete you have no neural tube, and the brain can't form properly, and you have craniorachisis. There is some forebrain sparing, as we'll see why in later slides, but this is again really a failure of the initiating events of neural tube closure. Exencephaly is a variant of this. It's more of a theoretical variant because it's rarely seen in neuropathological specimens. But basically, if craniorachisis is a defect of the entire neural tube closure, exencephaly is when the failure is really localized to the cranial neural tube, and the spinal neural tube closes properly. These are non-viable, so they lead to degeneration of the neural tissue of the brain and a process called anencephaly. And really, the brain does not develop. There's a defect in the skull, and therefore the fetus is not viable. So again, here's some pictures that I think illustrate the point from the internet. You have a complete defect from the brain down to the very caudal component of the spinal cord, and you have this characteristic defect on the back of the fetus that you can see looks almost identical in these various examples. This is just an example of when the defect is localized to the lower part of the spine. So these are the myelomeningocele. And so you have normal neural tube closure at the top, and then the defect can occur anywhere along the spine. So if we think about the brain, again, the severe ones are craniorachisis and exencephaly. If we're thinking about a defect localized to the spine, we're thinking about the classic open spina bifida, where there is a defect in neural tube closure in the spinal area. These are most often in the lumbosacral region, but it can occur anywhere along the axis. And we'll see why that is. And of course, you have, there's two variants of these. You can have a meningeal sac that's herniating through the defect, containing, as the picture shows, dura mater, spinal cord, and spinal fluid. But there's also a more open defect called the myelocele, where you will have an open, flat, exposed neural tube without the cystic component. These are viable. The brain forms normally, but there is severe disability that can occur in survivors because of the compromised spinal cord, especially at lower levels than the defect. So here's another picture just highlighting more of the open defect in these examples. I think this one is more intuitive, but it's important to know both variants as we see that the cystic structure appears to be the one that's highlighted more in books, autopsy specimens that I have seen. So it must be the more common finding. We'll get to this later on. Some babies may have associated hydrocephalus through a secondary defect known as Chiari II, but we'll talk about that later on in the presentation. So moving on from the true neural tube closure defects to perhaps defects primarily in the axial skeleton, we get into encephaloceles. these are mild to moderate, depending on the extent of the herniation and how much the herniated tissue is damaged through traction and compromised protection without having the skull covering it. But it's suffice to say that at least it's protected from constant exposure to amniotic fluid early on in development. So these are considered defects of axial skeletal development, where you do have nice neural tube closure, and then the mesodermal protective layer, both in the skull and the spinal cord, do not develop properly, leading to herniation of the meninges and the brain through the skull defect. You can have a variant of this is meningocele. So you can see this word does not have encephalo, which is brain. So you only have herniation of the meninges through the defect. And then again, just to kind of hammer through the definitions, so we can go back to the embryology and see how these form. The third type that we'll be talking about today, again, is technically not a neural tube defect in the traditional sense, but is really a defect of secondary neurulation. And we'll talk about what that means. But really, the variants are, you can have what's called diplomyelia, or longitudinal duplication of the spinal cord, and that's seen in figures panels C and D of this image. You can have hydromyelia, which is basically just a distension of the central canal of the spinal cord, and then you can have lipomeningocele, which is you have associated fatty tissue with the kind of bottom part of the spinal cord. The variant of spina bifida, as we mentioned, is spina bifida occulta, which is potentially somewhat of a misnomer, because we don't have that splitting of the cord in the traditional sense, but really there could be secondary issues from even though the nervous system is not directly compromised, again, from the amniotic fluid. You could have cord tethering, and it could lead to a lot of these variants seen in the lower part of the spinal cord. Again, these can be very mild, and so one book I read, it seems high, but 10% of people may have these defects, but they're fairly mild and asymptomatic. Why there's so many variants? Again, just thinking about some of the mechanisms, some of the definitions that we'll get to during the embryological component of this lecture. You can have defects of mesodermal development, where you have a bony sprue that is pushing against the spinal cord and leads to its duplication. Here you have two separate dural sacs and two separate cords, but there's also variants where you can have a single dural sac and the fibrous tissue being the element that is leading to the duplication of the process instead of the bony element. So different variants, again, that can occur within this kind of spectrum of disorders. So just a little bit about the epidemiology. These have an incidence of about 1 to 1,000 births. This has significantly changed in recent times as our understanding and ability to detect these diseases has improved. For example, in the 1960s, anencephaly and myelomeningocele, which are the most common neural tube defects, were about 1 in 5 in 1,000 births in the 1960s. Now they make up about 1 in 10,000 births. The reason for the dramatic reduction in the past decades has really been from the association of folate and dietary supplementation with folic acid in the past few decades, and then really prenatal screening that has really reduced the number of kind of births with these defects by 80% through early termination of fetuses with these severe neural tube defects. They are, however, higher in spontaneous aborted fetuses. So again, speaking to the fact that these can be associated with some syndromes, but are also just, even in of themselves, just not viable defects compatible with life. There are regions of the world that have higher incidences. This may be due to differences in practices of ultrasounds, termination of fetuses, and their acceptability, and then also how the country as a whole mandates folic acid supplementation. Some countries do put it in flour to help with compliance. Interestingly, one book I read has cited that there are some male-female differences, with females having a higher number of upper neural tube defects. This is the reason for this is unclear. Possibly that some of these are associated with syndromes that are more common in females. But interestingly, in animal models, it does appear that the kind of rostral neural tube does have a propensity to fail to close more often in females than males. The kind of embryological reason for this is unclear. With that said, the lower neural tube defects do seem to have a more balanced male to female ratio, and these are often isolated lesions. So again, risk factors, most of them are non-genetic. Maternal disease states, exposures to teratogens, as we'll see what exactly teratogens mean. But most common being kind of poorly controlled maternal diabetes. Hypoglycemia and ketone bodies are in and of themselves teratogenic. So having a high uncontrolled diabetes does increase the risk of neural tube defects. Obesity has been linked to it, although this has not been fully established in some of the books I've read. Hypothermia, this is a good exam question. Fevers, excessive sauna use. Again, something that you may see on an exam, but it's unclear if this is in fact true. The association with valproic acid and other kind of neuropsychiatric drugs does seem to exist, with 20-fold increased risk of myelomeningocele when taken early on in pregnancy. The main kind of breakthrough in this field has been folic acid, where there has been an association with folate levels and neural tube defects, and subsequent fortification with folic acid, either through a prenatal vitamin or fortification in flour, does seem to significantly reduce the number of neural tube defects, although does not bring it down to zero. Now, there again, this folic acid does not solve all the problems, so there may be some genetic components that may interact with these non-genetic elements to lead to an increased propensity for neural tube defects. And in fact, there are some kind of polymorphic changes in folic acid-related genes that have been associated with neural tube defects in the mother and fetuses. And here's just a little table that highlights some of those genes, and really the majority of the genes are involved in this folic acid cycle. Why folic acid leads to neural tube defects and failure of neural tube closure is unclear, but as a process that's involved in proliferation and DNA synthesis, you can imagine that in this period of rapid expansion of that neural plate to kind of come up and fold on itself, that sounds like it requires a lot of increase in volume. If you don't have the right cofactors and components to expand the nervous system cell numbers, you're not going to be able to kind of buckle and close properly to close the neural tube. So I think this is the, if you need a slide to remember things, this is the one that I think groups them the best. And as we talked about this already, I won't belabor the point, but I think this is a very nice way to remember the disorders as failure of neural tube closures. then you have failure of the kind of axial mesoderm to form the vertebral body and skull surrounding the neural tube component, and then a separate entity, which is a failure of tail bud development or secondary neurulation, leads to some of the more minor things. So hopefully this is useful for you guys to remember these concepts. There are some anatomical frameworks, but again, I think understanding the embryology helps you learn both the embryology, but also helps you remember these in a very coordinated way. So this is kind of a cartoon of a fetus highlighting that there are multiple closure sites that occur, and really highlights how these closure sites and stages of neurodevelopment are associated with the different disorders that we're talking about today. So neurulation is actually divided into two steps. There's primary neurulation, which is the one that you see most often in textbooks when you Google what neurulation is. This is really just the neural tube folding and then fusing to form the neural tube from the neural folds and neural groove. And then secondary neurulation is this kind of colored in area here. It happens really at the very caudal end of the embryo, and really forms a neural tube through a completely different process through condensation of mesenchymal stem cells and canalization to form this kind of neural tube structure. And because of that mechanism leads to some of these weird defects that occur at the caudal ends of the spine. So this is a nice figure because it shows that there's multiple closure sites. And if you understand the closure sites, you'll understand why the fetus looks the way it does. There's this closure site at the back of the kind of cervical area of the fetus, which is the primary closure site. And this will zip up the neural tube, kind of both rostrally and caudally, to form the spine and the kind of forebrain. But there's also some other closure sites that have been identified at the kind of most rostral end that will help the neural tube close and then meet up with the primary closure site. And you can hopefully understand how this can lead to exencephaly without necessarily leading to craniorachisis. So you have craniorachisis when you have a failure of this major closure site to close and zip up, whereas you can have more focal exencephalic lesions that occur when this closes properly, but there is a defect in the second or third closure site. And then again, you can have a perfectly normal structure and then just have these tail bud defects because of this separate neural tube process. When this zipper doesn't form properly at the kind of end of its zipping at the posterior neuropore, then you can have the lumbosacrospinal bifidus. Again, here's just another cartoon. If these concepts are new to you, so this the first one is looking at the kind of nervous system early on in development. So this is like week 2 and 3, where we have a 3-layered structure we're looking at the kind of ectodermal structure here, which is induced to form this neural plate in the center, and then this will fold on itself using these neural folds and neural crests, and then fuse in the middle to form this neural tube, right? And then you can see here, these dots here are the somites. These are mesodermal structures that are going to form the vertebral elements. I like the kind of transverse view. You can see here the notochord is going to stimulate the ectoderm to form these neural folds and neural grooves. These will fold on itself and fuse in the middle to form the kind of the neural tube. And then the kind of remainder cells at the fusion will be the neural crest cells that will form various structures in the body, including sensory neurons, Schwann cells, bones of the facial skeleton, and skull base. So important to know that as we discuss these concepts. So here is another kind of a picture of a fetus that shows the different closure sites. And again, the importance of these closure sites is that if we look at where they're occurring, and if you remember those images that we saw of the encephaloceles, you have encephaloceles being very common at these closure sites, with occipital encephaloceles and these frontal encephaloceles being very, very common. As we'll see, most of the craniorachisis is thought to be a defect in this kind of cervical neural tube closure initiation site, but the fact that we'll see that so these fetuses have fairly normally developed faces suggests that there is good closure at the kind of prosencephalic component of the anterior neural pore, right? So again, you have closure, it zips up the spinal cord, moves up, and then you have different closure sites that may be involved in helping close an anterior neural pore. So again, neural induction, you have these neural plates, which are basically thickened dorsal midline ectoderm structures through inhibition of BMP through the release of certain substances from the notochord, like noggin and other kind of secreted molecules that signal the ectoderm to become neuroectoderm. This again leads to what are called neural folds. These will fuse in the midline and usually occurs in the kind of second to third week of fertilization. Basically, the fusion begins day 22 in the cervical occipital region, and then continues rostrally to form the brain, and then caudally to form the spinal cord. And basically, as you mentioned, there's additional closure sites in the kind of rostral terminal end of the anterior neural pore. The whole process is done by day 26 to 28. So within the first 4 weeks of life, your neural tube is pretty much set in stone. And this is why folic acid supplementation is so important as a prenatal vitamin, because this event occurs even before many mothers know that they're having a baby. And so if you don't supplement folic acid even before mothers want to conceive, or perhaps know that they've conceived, you are in fact risking missing the window of opportunity to prevent these severe disorders from forming. And this is why we need to raise awareness, and this is why some countries have fortified things like flour with folic acid, just to prevent missing this window of opportunity. Okay, so as we talked about, that happens within the first 4 weeks. The other major milestone that's important to kind of conceptualize in that kind of timeline of neurodevelopment is the development of the skull and the vertebral bodies. These are mesodermal structures that will migrate to these somites will migrate around the formed neural tube and form the vertebral bodies and the skull, usually around week 10 to 15. So while the brain is still forming its neurons, before gliogenesis, you already have the skeletal structure set for the nervous system. In the cranial regions, only the vault of the skull forms, with the skull base and facial skeleton being derived from migratory neural crest cells around week 6. This is important if you need to kind of figure out why some disorders it appears that the fetus has a normal facial skeleton. It's just lacking the kind of flat bones of the calvarial bones of the skull vault, because they're embryologically derived from different components. But the occipital region of the skull and and the spinal cord are really formed from the kind of sclerodermal cells, sclerotome cells of the mesoderm. Interestingly, development of the skull and spinal cord appears to require interaction with dural elements. And therefore, when you don't have neural tube closure, you're going to have defects in your skull development because the two are inherently connected. And this is why I think it's important to group these disorders together, even though they're embryologically appear to be distinct, because if there are defects in focal areas of skull development, one may assume or presume that there may also be some subtle defects in how the neural tube closed that may be leading to the reason why you have the skull defects. And again, the interesting thing about these encephaloceles is that they usually occur near these closure sites that we saw, suggesting that it's not random kind of defects in skull development focally. So defects in skull and vertebral development can occur with apparently good neural tube closure, and then leads to herniation of the neural tube outside the spinal cord, right? So, and again, usually occur at the neural tube closure sites, which is suspicious to me, suggesting some sort of maybe subtle or microscopic defect that leads to this. Tail bud development, again, this is a kind of a weird way to understand what the structure is. As the name implies, it's really a big component of the tail formation and other kind of lower structures in animals. And unlike this kind of neural folding and neural tube formation, in primary neurulation, you have this condensation of stem cells, of multipotent cells from the mesenchyma that condense together and form a secondary neural tube just at this lower region of the spinal cord. Again, here's just another nice little diagram highlighting the difference between primary neurulation and secondary neurulation. And this is why these events occur in isolation from the kind of primary neural tube defect. So again, it's really formed from a collection of multipotent self-renewing stem cells in the lower part of the spine. These are remnants of the primitive streak from gastrulation, and really is the tail bud is the sole source of non-epidermal tissue of the lower levels of the spinal axis. So these will condense to form things. Neural tube, somites, hindgut, notochord, and so really in that focal area. And defects here usually occur when there's ineffective separation of that neural tube with the surrounding mesodermal structures, and then you get tethering. And this, makes sense intuitively because, again, you're really trying to form a structure from just condensation of this mesodermal layer. And so it kind of makes sense that the defect here would be in the kind of the clean separation of this neural tissue from the surrounding mesodermal structures. And because it's a multipotent tissue, this explains why you get some weird things forming here, like lipid within the spinal cord, as we'll see. You can have teratomas. Again, these are really multipotent cells that just have failed to differentiate. And as we mentioned, this is really the structure that forms the tails in animals. So genetics, again, the genetics, the focus has been on folate metabolism since the association with folic acid supplementation being productive was identified. And a lot of these genes, again, are just part of that kind of pathway that we saw. There are, however, other genes, if you do kind of mouse-wide, genome-wide knockout studies in mice, there are about 80 candidate genes that lead to neural tube defects in mice. some, a small number appear to be involved in neural initiation of neural tube closure. Other genes can kind of result in cranial and lumbar specific defects, suggesting that some genes may have may kind of be more involved in anatomically different locations of neural tube closure, as we saw, and these may kind of drive specific defects and specific genetic backgrounds. And then these kind of genetic studies have also found some genes are involved in formation of somites to form the vertebral column, right? So everything checks out. If these are related, if the mouse ones are related to the human ones, still remain to be seen. But I think the take-home message is folic acid supplementation, fortification to prevent low folate levels in unsuspected mothers could help reduce these. That would be I think the board question you may get. These are just some pictures of mouse embryos showing different mutants having different patterns. So the cell SR1, which is involved in a cell polarity, you have craniorachisis with the whole entire spinal cord and brain being exposed without good closure, whereas other mutants, you can have very location-specific herniation, as in this example, showing exencephaly. Some clinical features, again, craniorachisis and encephaly are incompatible with survival beyond birth, since the central nervous system is compromised, and they're usually almost exclusively seen on ultrasound and pregnancy. Severe spinal neural tube defects and occult spinal neural tube defects are compatible with life, and about 15% of myelomeningocele will proceed to birth in the UK due to the vast majority are diagnosed and terminated in many developed countries, maybe contributing to some of these variations depending on which country you survey. Survivors of spinal tube defects can exhibit severe motor and sensory deficits below the level of the lesion, including incontinence, urinary tract infections, and of course the outcomes will vary depending on the severity and which levels are involved. Some patients can benefit from cesarean section and the early surgical repair of the lesion following birth, and can be accompanied with kyphosis with a curved vertebral column, and hydrocephalus that may require shunting, such as this Chiari II that we'll talk about. So diving into the neuropathological findings, let's again go through the different disorders and see how they're related. So again, in craniorachisis, the brain and spinal cord are degenerating from exposure to the surrounding amniotic fluid. And so grossly, you have degeneration of neural tissue and the formation of angioma-like tissue with very vascularized, degenerated brain tissue, as shown in this microscopic image. So exencephaly, we talked about this. This is just basically a defect of the kind of rostral component of the neural tube with herniation. The reason why this is not often seen is that because of the rapid degeneration, it usually leads to a very similar picture to craniorachisis with anencephaly being formed. So anencephaly is basically, you have a hypoplastic calvarium with absent and or it could be completely absent, and then you have kind of the skull base is thick and flattened. You have sphenoid bones, which are thought to have a kind of a bat with folded wings like structure, and then you have shallow orbits causing protrusions of the eyes. And then the key thing, when you look from the back, you have this area cerebrovasculosa, which again is this kind of degenerated, very vascularized tissue, which sits at the skull base and may be associated with kind of cystic cavities with CSF fluid. In some areas, it's very hard to recognize any of the neural tissue, depending on how long it's been degenerating for. The cerebellum, pons, medulla, those structures in the back near the mesencephalon, they're usually grossly absent, and the spinal cord involvement varies depending on how much of it was completed. Microscopically, we see it here. You have vascularized tissue with kind of primitive neuroglial tissue with vascular proliferations, and so there's really nothing more to say. It sometimes can be linked to the neighboring skin tissue, again, making sense because it's really a derivative of the ectoderm. And so if there's a failure to close, it would make sense that it can still be associated with this neuroectodermal structure. So the medulla and the spinal cord may be well preserved in some cases, but of course the descending tracts will be compromised because those are derived from the central nervous system. And again, the left meninges may also have highly vascularized changes in heterotopic neuroglial islands. So here's some gross images showing what this looks like. So this is craniorachisis. Both the brain and the spinal cord show a failure of neural tube closure. And again, the arrow on the left is showing this kind of hemorrhagic vascularized tissue that sits in the base of the skull. That is the area cerebrovasculosa. Another example from looking that you can see from the front, as we'll see, a common theme is that the facial structures are relatively well formed, which is characteristic of these lesions. Here's another example here where we see the defect from different angles. So in the left side of the image, we see a fetus from the front with those kind of protruding eyes from the kind of malformed orbits, but the facial structures seem to be okay, and the presence of the eyes suggests that there may be normal prosencephalic development early on. From the top view, you can see that vascularized tissue without the skull formation. This is encephaly. This is the area cerebrovasculosa, and then you have these kind of microscopic images showing this very well demonstrated here with kind of the normal orbits, and then the cerebrovasculosa associated with the normal skin appendages. And then again, the bottom picture, unrecognizable, just seems like vascularized tissue. This is the area cerebrovasculosa on the microscopic level. So moving on to severe neural tube defects, failure of closure of the lower portion of the neural tube. Here we have a milocele, which again is that a kind of open book-like neural tissue, and then a myelomeningocele, which is basically with the associated cystic herniation of meninges and this incompletely fused spinal cord. So myelomeningoceles, this is the most severe form of spinal neural tube defects as a cystic mass herniating through the vertebral defect that couldn't form because you couldn't have proper neural tube closure. Usually there's a meningeal sac filled with CSF and is covered by a thin layer of membrane or skin, and then the spinal cord within this may be closed, it may be floating or stuck to the posterior aspect of the cyst. My suspicion is that part of this cystic component is normal closed a spinal cord higher up, because then how would you have the kind of the meningeal component forming the cystic mass if it was completely open? So I think intuitively a milocele makes more sense from an embryological perspective, but it does appear that this phenotype is less emphasized than the myelomeningocele, at least from my readings. The milocele is a flat open lesion with CSF leaking directly from the exposed area. And like the area cerebrovasculosa, we need a new terminology for this in the spinal cord. So it's called the area medullovasculosa, which is basically the same thing. Again, microscopically, vascular fibrous tissue with islands of neurons, glia, and ependymal cells can be associated with Chiari II, which is basically hydrocephalus, herniation of the cerebellar tonsils through the foramen magnum. And it's thought to be due to cord tethering or pulling of the spinal cord down from this kind of immobilized lesion in the lower part of the spine. There could be other associated things higher up, syringomyelia, hydromyelia, diastomatomyelia, diplomyelia, again, suggesting that some sort of traction or defect could be pulling on during development and lead to these defects higher up. So here's some, again, gross pathology of these defects. Again, from the back, we see a defect of the skull development and no brain tissue. A side view, again, highlights that there's really a normal facial structure for the most part, or at least developed facial structures, and then complete absence of the kind of calvarium and skull bones being formed at the top, which is the kind of associated anencephaly. And then we have a myelomeningocele shown here on the right, with exposed spinal cord. It looks like the cyst here ulcerated, or at least the skin ulcerated, and you can get you're getting direct exposure of the nervous system to the amniotic fluid, or in this case, at the autopsy. This is another term that you may come across called encephaly, and in some cases, especially with craniorachisis and cervical myelomeningoceles, you have this severe retroflexion of the neck. And so if you do see this, this is an understood phenomenon, and there's a term for this. So no need to reinvent the wheel, or this is well understood. Why this occurs, it's unclear, possibly due to some torsion or some flexion of having the spinal cord not freely floating in its correct kind of canal and being exposed to the external environment. So going back to the hydrocephalus issue, some of these examples where you have a myelomeningocele, you have associated hydrocephalus, and more than that, you have what's called a Chiari type II, or anal Chiari malformation, and these are associated with myelomeningoceles. And basically, the key pathological findings here are that you have this caudal displacement, so downward displacement of the cerebellar tonsils and medulla oblongata into the foramen magnum. And then this is thought to kind of impair CSF flow and lead to hydrocephalus in the brain. Here's kind of twins, which you have Chiari type II in one fetus and a relatively normal cerebellum for comparison in the subsequent fetus. Just showing the contrast in a kind of more well-controlled system. The mechanism of this has been contentious, but it's thought that there's some caudal traction of the cord from the defect that's pulling the spinal cord and brain down. And the support for this is that when you fix the myelin in utero, it does seem to help reduce the hydrocephalus higher up. So it's contentious whether these are separate defects or secondary from the initial defect. But to me, practically speaking, I think it's easier to understand it as a cord traction issue. So moving on to the encephaloceles, again, defects of mesodermal defects in the axial skeleton and herniation of neural tissue through these defects. So cranial encephaloceles and meningoceles, 75 to 85% occur in the occipital region and can be large and covered by skin and hair. So again, these are not randomly distributed along the midline. There's very specific locations that these occur, usually in the frontal element and usually in the occipital element, and some people have associated them with those closure sites, suggesting to me that there is potentially some defect in the neural tube closure that may be more mild than the severe ones that may be leading to impaired axial skeleton formation. The skin covering it can be normal, it can be ulcerated, it could be infected, and so again, the degree of impairment really depends on a number of factors. Microscopically, you have disorganized and gliotic brain tissue, including glial and ependymal elements. When you see an occipital encephalocele, it's important to think of Meckel-Gruber syndrome. This is an autosomal recessive disorder that maps to chromosome 17, and the gene that has been associated with it is involved in primary cilium formation. So again, migratory elements of cells. The key here is that this is an entirely different mechanism than dietary folate supplementation. No amount of dietary folate may be able to reverse Meckel-Gruber syndrome. So if you recognize this, it's important to think about other differential diagnoses that may have different family planning issues for the parents. These are often associated with other things that may kind of make you more suspicious, including a sloping forehead, occipital encephalocele, we talked about polydactyly, polycystic kidneys, hepatic fibrosis, palate-like proliferation, midline patterning defects of brain structure. So much more than just a herniation of tissue. Anterior encephalocele, again, usually occur in this frontal ethmoid junction, as we'll see, very characteristic, and again, basically look the same, disorganized and gliotic brain tissue. You can have a meningocele, which, as its name suggests, is just a herniation of meninges without neural tissue, and we'll see examples of that, and may show other anomalies such as hydromyelia, syringomyelia, and cord tethering when they occur lower down. So overlying skin is usually thin from probably the pressure, presumably from the cystic structure, simplified and vascularized skin elements. So here is an example of an occipital encephalocele in panel A, with again brain and meninges herniating through the defect in the skull, and the surgical specimen shows vascularized and disorganized cortical tissue with some ventricular elements. The other image shows an anterior encephalocele with brain herniating through this kind of ethmoid nose area due to the defect in this area too. So non-random pattern may suggest some, again, some defect in that neural tube closure. that could be subtle. This is just my theory, but something that I thought was interesting to note. Here's some microscopic images, again, showing brain tissue. There's inflammation. It's highly vascularized, reactive tissue, does not look to be happy. Again, it doesn't have that protective skull barrier, so it's subject to mechanical force and physical force of the external environment, even though there's no direct contact with the external environment. Here's some more examples. You can see this on an ultrasound. Here's the same baby with the skin covering the cystic herniation of brain tissue through the skin. If you poke it and you open it, this is it dissected. You can see the brain tissue is herniating through the defect. And then microscopically, this is the cerebral aqueduct with hemosiderin, disorganization. Again, classic, nice example of this occipital encephalocele. Here's another one from the same book. You have, again, intact skin structure with herniation of the kind of cerebellar tissue and some disorganization of the canal here of the vertebral system, ventricular system from this defect. This is an example of a meningocele, so looks very different, doesn't have that kind of pinkish, whitish appearance on gross exam that we saw with the other ones, because it's mainly formed with meninges and spinal fluid, so there's no brain tissue in these. And then these can form kind of fibrous bands to normal brain structures within them. And so even though they seem more benign, they could lead to secondary defects such as hydromyelia and other defects from this kind of tethering and pulling of the nervous system, especially early on in development. It's important to note that you can get mimics of these kind of neurodevelopmental defects that you should think about. One is amniotic band syndrome. This is really a here's a good example of that, where you have herniation of the brain through a skull defect. This may look like exencephaly, but really what's happening here is that you have compromised you've compromised the amniotic barrier here. It's torn, it's ruptured, it's compromised. These lead to these fibrous bands that can constrict and bind to components of the fetus and lead to amputation of limbs, amputation of fingers, constriction of fingers. It can also bind to the cranial components and lead to ischemia. And so you may have these are not neural tube defects. These are different types of defects with different implications for the family. And the way you're going to recognize these is you're going to look for other stigmata of amniotic band syndrome, constricted fingers, toes, any amputated limbs that may suggest something else is going on. There's also a similar or kind of related defect called acalvaria, where you have complete absence of the bones of the calvarium, and usually these are due to defects of bone development, skeletal dysplasia, as shown in this panel here, osteogenesis imperfecta. You see normal skin. The brain tissue is under the skin here, but there's just no cranial vault being formed here because of this defect in bone calcification, mineralization, whatnot. This brain, I believe this is from this autopsy here, and then there's other syndromes that may lead to complete absence of the kind of cranial vault, and the brain tissue may look quite normal, but this complete absence rather than a more focal defect may suggest something else is going on. I think this is a trisomy 21. It's from this reference here if you want to double check. But there are other things to consider than just these neural tube defects. Lastly, we're getting into these defects of tail bud development. Here's a nice example of hydromyelia. These are less severe, obviously, and basically there could be hydromyelia or overdistension of the spinal canal, as shown in the top panel. There could be split cords. There could be duplication of the spinal cord, as we saw. There could be splitting of the cord. So diastematomyelia is that there's a splitting of the cord and then a complete frank duplication. These may be in separate dural sacs. It can be in a single dural sac. And really, I think the fundamental thing is that there's tethering of the lower cord because of incomplete separation from the mesoderm during this condensation of secondary neurulation. Just because there's tethering at the bottom, I think that could lead to some of these other defects higher up. So just to keep that in mind. There's various combinations. Something mechanistically different is like the spinal lipomas and dermoid cysts. I think these are not necessarily due to tethering, but due to aberrant differentiation of this kind of multipotent mesenchymal mass. So that's important. We'll show examples of that. And again, can be associated with some lower limb sensory and motor deficits and neurogenic bladder, but can also be completely asymptomatic. And there's different treatments depending on which of these defects you may have. Here's a nice example of intradural lipoma. Again, incomplete differentiation, aberrant differentiation of these progenitors in this lower spine. I think the key clinical message is prenatal diagnosis. You can measure alpha fetoprotein, acetylcholinesterase in the amniotic fluid, and alpha fetoprotein in the maternal blood. This is spilling of a substance that's made in the brain in the maternal blood due to open communication, and that implies that there's an open neural tube defect. Again, these will only occur if it's a true open neural tube defect. If you have something like encephaloceles, where you have reasonably good closure or complete closure of the neural tube, you won't have this spillage of alpha fetoprotein from degenerating neural tissue to detect. You can, however, detect most of these, as we saw in previous slides and in this one too, using advanced imaging. Ultrasound can pick up neural tube defects. You can pick them up with with MRI, which again, in many developed countries, these will lead to kind of early abortions due to the severe symptoms that these patients may exhibit, and so they will vary depending on how good the screening program is and what the cultural beliefs and accepted practices are of that specific region. But the best thing you can do is prenatal vitamins with folic acid. Folic acid is just the man-made version or the human-made version of folate, which is the kind of the naturally occurring substance. We don't absorb folate extremely well, so supplementation with folic acid can ensure that you have the appropriate levels during this critical period to reduce the incidence of neural tube defects. And again, it's important to know that these are occurring fairly early on, before a mother knows that she's pregnant. So starting prenatal vitamins early, even during your ages of conception, and even supplementing foods with them may help prevent these. So thank you Sorry about the duplication of material throughout the presentation, but I think these are relatively simple but complex concepts that that require you to go back and forth between neuropathology and embryology to kind of consolidate the knowledge in a way that you can remember for many years. So I hope that was useful. Thank you very much. We have other neurodevelopmental videos on NeuroPsyQ. So if you found this helpful, you're interested in neurodevelopment, please do check those out. And stay tuned for more similar content in the coming weeks. Thank you.